I believe that Tom may be listening, but I'm going to do the unknowns this week. Tom will still be taking the reins of this program and doing it many times, but we are also going to have some of the other physicians in our practice work with you all, and I think that'll give also you all a perspective of other pathologists. Just to give you a little background about me, I did my training at Southwestern Medical School in Dallas in pathology, finished APCP, got boarded in that, and then did my fellowship in New York with Bernie Ackerman, and have been practicing Dermpath ever since. I was the lab director at the Ackerman Academy for years prior to Bernie passing away, and then stayed on for a few years and then left after he passed away. I joined Sagis, partnered with the two other partners in 2015 and haven't looked back. If this is very much going to be like Tom does it, the unknowns that you all have previewed on Path Presenter on our virtual microscope. We'll go through the answers and some of the differentials. If you all have any questions, you can ask them through the question and answer box. I'll try to get to them. If I don't, maybe we'll be able to get to them afterwards or email you. I know Tom gives you his cell phone number. Mine is, and maybe Ida, who's listening, who coordinates this, can write this down and text it to you all or whatnot. But my cell phone is 646-245-0763. If you all have any questions, I'd be happy to speak with you afterwards or anytime. And then also you can email me at tmartin, that's TMARTIN, at sagisdx.com, SAGISDX.com. And with that, I think we'll dive right into the unknowns. This is the first one. I've put it here on low power. I like to start on low power with everything because it gives you kind of a overview of what's going on. And even at low power, you can see that the epidermis is not thickened or significantly involved by the process. And you can actually somewhat draw a line around the process here. In fact, oops, sorry. Go back to my pencil here. You can see you can draw a line around the process. And that's important, you know, and you can even see that there's some sparing between the epidermis at the top and the neoplasm or whatever process is going on. As we go down to a little bit higher power, clear that, you begin to see, you begin to see a neoplasm taking shape. And as we go even to higher power, we look to see what the neoplasm is composed of. And it seems to be composed of round, almost polygonal cells with this abundant granular cytoplasm, some central to slightly eccentric small nuclei with some inconspicuous nucleoli. So really, we begin to think of a histiocytic process. Either if these are true histiocytes, then these would be clusters and aggregates of histiocytes, in which case it would be a granulomatous process. If it's a neoplastic process, it could also be composed of neoplastic histiocytes or other cells. And many times we look for clues to our diagnoses. And I think the big clue here is the granular, this distinctive granular cytoplasm. I mean, if that's not granular, I don't know what it is, but that is truly a beautiful granular cytoplasm. And when you have a histiocytic, almost looking neoplasm with granular cytoplasm like this, you immediately begin to think of a granular cell tumor. And how would you then verify that? Most pathologists would, if they're not comfortable signing this out, you could throw on an S100 immunostain and it would be positive for that. You could also throw on a CD68 to see if they're histiocytes or if it's a granular cell tumor, but oftentimes granular cell tumors are CD68 positive, so that's not going to help you too much. But anyways, so this is a granular cell tumor. Now the question becomes, is a granular cell tumor benign or malignant? After all, it's just called a tumor, right? And I think when they were originally describing this, they did that on purpose because these can behave either benign or in a locally aggressive fashion. Very rarely do they metastasize. Now, the benign ones have no necrosis. They're relatively circumscribed, though unencapsulated, and are very banal appearing cytologically. And this would be a benign granular cell tumor. Then there's the category where they have a few mitoses and maybe a little bit of atypia to the nuclei, in which case they're called atypical granular cell tumors. And then there's malignant granular cell tumors, and pretty much everyone agrees that the true criteria for malignant granular cell tumor would be metastasis. Now, how do you define malignancy? First of all, metastasis would be a great way, but second of all, they can be locally destructive. And I have seen a, quote, benign granular cell tumor. I had it many years ago that was in the bottom aspect of the foot, and it grew around all of the tendons, ended up growing up the ankle, and they ended up having to cut the whole, to amputate the leg. So, you know, is that malignant or not? But anyways, so most people do recommend that these just get conservatively excised so that they don't recur if they're not frankly malignant. Let's move on to the second one. Let me turn this around so it's, I like to look at everything the way it would be anatomically. Let me get this around here. So here we have a punch biopsy of skin, and I can't get this. Here we go. Here we have a punch biopsy of skin, and on low power, what is it remarkable for? It's remarkable for the thickness of the dermis. If you'll notice, the epidermis appears relatively uninvolved. We have an extremely thick dermis going all the way from here all the way down to maybe right there, where we begin to see a little bit of fat down here, and very little subcutis. So in what seems to be a very adequate punch biopsy, we have very little subcutis. So what does that tell you? That tells you that the dermis has markedly thickened in this process. As we come down, we can start at the top. I like to go in a very logical fashion. So when we start at the top, again, we can see that the epidermis is not showing many changes, maybe slightly thickened right here at the line. But then when we come into the dermis, we begin to see a patchy perivascular lymphocytic infiltrate here, maybe periadnexal down here. Oh, sorry. Maybe periadnexal right here, because perhaps this whole line right here is a follicle coming down. And we also see a little bit of, and I think this is a red herring, but we see some histiocytes right there. But I think that's probably because this follicle ended up rupturing at some point. But nonetheless, we have a markedly thickened dermis with thickened collagen bundles. And as we come down, we see more of that inflammation down here in the center of the screen. And if we check out that inflammation, we're going to see it's composed of lymphocytes, which are these small, the small round cells right here. And we have some histiocytes, which would be this cell right here. And importantly, we have plasma cells. Here's a cluster of plasma cells right here. See the nucleus that's pushed off to the side with a perinuclear light Hoff, and the nucleus almost looks clockwork, like a clock face. Those are plasma cells. So we have an infiltrate composed of lymphocytes, histiocytes, and plasma cells with thickened collagen bundles and thickened dermis. This is an example of Morphea or scleroderma, depending on your view of the two diseases and whatnot. But so that this is pretty characteristic. And again, you can really hone down on the diagnosis on the low power because you see that thickened dermis and this beautiful punch biopsy with parallel sides and perpendicular bottom, almost forming a rectangle. What would the differential here be? Well, on low power, we have an absence essentially of any adnexal units, so that hair follicle that was right here in the center is gone. We have no sweat glands. I don't see any sweat glands in this region. We should be seeing sweat glands somewhere around there. So we have no follicles, no sweat glands, no apocrine glands, nothing. We have an absence of adnexal units. You do see that in Morphea, but you can also see that in radiation dermatitis. In radiation dermatitis, you would expect two other findings. One, you would expect bizarre multinucleated fibrocytes or pleomorphic fibrocytes in the dermis, which we do not see. We do not see those there. And also in radiation dermatitis, just like the sun alters the elastin fibers into blue fibers, it will do the same to skin. The radiation will do the same. So you'll see solar elastosis, if you will, but it's basically radiation-induced solar elastosis, which we don't see here. So I think we can confidently say that this is not radiation dermatitis. You could also see similar changes in ischemia of any cause. So you might want to look down at the bottom and look for any vasculitis. I don't see any vasculitis that would be leading to an ischemic process. I don't see any ulceration. I don't see any frank necrosis. And you can go down into the small blood vessels if you can find them. They're kind of atrophic in Morphea, and make sure you don't see any occlusion by like fibrin thrombi or something like that. So you can rule out ischemia in that sense. And one other thing that you need to be thinking about is nephrogenic systemic fibrosis. So, you know, a gadolinium contrast study associated disease in a patient often with renal failure. And in that case, you would see an increase in nondescript, almost spindled cells here in the dermis. And if you put on a CD34 immunostain, they would be positive. So we rule out all those other things, and it looks like Morphea, so that's our answer, Morphea. Let's move on. Next case. This one's kind of fun. This one, if you didn't see it, it will be obvious once we begin to point it out. But on low power, let's start on low power. We have, again, the epidermis now here, we have something going on in the cornified layer here. So above the granular cell layer, it's thickened cornified layer, and it's even vesiculated right here. So we know something's going on there. And we also have a perivascular infiltrate of blue cells, which look like lymphocytes at this power. And the subcutis looks relatively spared by the process, if at all involved. And as we come down on higher power, we confirm that those are indeed lymphocytes in there. But what else do we see besides lymphocytes? We begin to see some neutrophils. Here is a neutrophil right there. And we see a cluster of eosinophils right here on that. And as we come up, let's check out what's going on here in the epidermis that we saw on low power. The epidermis has neutrophils percolating through it. There's fluid in between the keratinocytes, as you can see here. They're separating a little bit. And we have here above and at the granular cell layer a split filled with neutrophils. So we have a split filled with neutrophils. And here's the cornified layer up here. And as we can see, we begin to look, we can see some blue, purple, filamentous things going on here. And as we go down to higher power, we see that they're fungal organisms. So this is in fact a tinea, so a dermatophytosis that's resulted in vesiculation and suppurative inflammation. If y'all saw that, then you got it right away. If you didn't, what would some of your differentials here be? Well, you need to be thinking when you see a split between the granular cell layer and the cornified layer, you need to be thinking of impetigo can do this. So, you know, a staph or strep associated impetigo. So you can do a gram stain and look for any gram positive bacteria in there. You would have done a PAS stain to look for fungus. In this case, it's a raging example of fungus, but it can be very subtle too. The other thing that you need to be thinking of whenever you see a split above the granular cell layer is staphylococcal scalded skin syndrome. But in that case, you would have, it would be paucicellular. There would be very few, if any, neutrophils there. So we can confidently rule that out. One other thing you might be thinking of when you see a split high in the epidermis would be superficial pemphigus. But again, we see very little acantholysis per se here. and we just have a split, and we also have all these neutrophils. So you don't see that very often in pemphigus unless it's secondarily impetiginized. So those are all the things you need to be thinking about when you see this. And you know, it's often not this obvious, the fungus, but in this case it was. Let's move on to case number 4. Case number 4. So on low power, we have, you know, they embedded this in a almost in a radial fashion. You very rarely see this, but here's the bottom of the biopsy. And then you have epidermis. You have epidermis coming all along the top. And here is the bottom down here. So you could carry that all around across. So basically this is a polypoid lesion that was sticking above the surface of the skin that they just shaved the top off. As we come down, we're not quite sure if this is inflammatory, if this is neoplastic at this point, but we do see that the epidermis is relatively spared. So we're going to go down into the dermis and see where the money is here. And when we come down into higher power, we begin to see a couple of cell types here. We see, most strikingly, enlarged histiocytoid cells, some with almost ground glass appearance right here. Some would term that ground glass cytoplasm. There are other areas where those same types of cells are multinucleated. Here's a multinucleated one. Oop. All right. Here's a multinucleated one. Let's keep looking around. So we have lymphocytes, some large histiocytoid cells, multinucleated. Oh, here's one right here where the nuclei are rimming the periphery. See this? Rimming the periphery. Rimming the periphery. Oh, look at all those. And then we see what we're finally looking for right here. We see one where the nuclei are rimming the periphery, and at the periphery you have foamy cytoplasm or slightly vacuolated cytoplasm. So this is what you would term a two-ton giant cell, T-O-U-T-O-N. Some people remember it as two-toned because the center is often eosinophilic and the periphery is pale with the foamy cytoplasm and the rimming. So those are called two-ton giant cells. So when we have a mass of two-ton giant cells, histiocyte-looking cells, some ground glass cells, lymphocytes, you might even find eosinophils in here, but this is a Xanthogranuloma, and here's a beautiful two-ton giant cell right here, where the center is one tone, which is eosinophilic, and the periphery is another tone, which is pale and slightly vacuolated and foamy. So this is a Xanthogranuloma. You know, for immunostains on these are generally CD68, which is a histiocyte marker positive, and for the most part, they're S100 negative. A few of the cells are often S100 positive in these, but overall, the tumor is negative. The differential here, there's not much of a differential with this one, with all these two-tone giant cells, but these have different phases that they go through. Early on, there's very few two-tone giant cells, and it's mostly just these nondescript histiocytic-like cells like you'd see right here. You would see a bunch of these cells right here, and some lymphocytes, maybe a few neutrophils, maybe a few eosinophils. And early on, they can be very difficult to recognize as a Xanthogranuloma. And then as they age, they get more of the two-tons. So sometimes you do have to end up thinking, well, could this be Langerhans cell histiocytosis? In which case you could throw on a CD1A, which would be positive in Langerhans cell histiocytosis and negative in Xanthogranuloma. And in general, the Langerhans cell histiocytosis is going to be diffusely S100 positive, while this will only be focally S100 positive. One other thing to think of would be a reticulohistiocytoma. So if you had a neoplasm composed entirely of cells like this, with this ground glass appearance, then that would be a reticulohistiocytoma. And many consider reticulohistiocytomas and Xanthogranulomas to be a spectrum of morphologic, histologic neoplasm, although there are different implications for a reticulohistiocytoma, which can be a systemic process, or they can also be solitary. But that's your differential. But once you've seen these two-ton giant cells, and remember that for your boards, if you don't remember anything today, two-ton stands for two-tone. Once you start seeing those, think of Xanthogranuloma. Okay. Let's move on to case number 5. Case number 5. Let's turn it right side up. I don't like looking at stuff upside down. Okay, case number 5 on low power. Again, we kind of like our first case, we can draw a line around what seems to be the process right here in the dermis. Okay, the epidermis seems relatively spared, though may have a little bit of hyperplasia right there, but it also actually seems to be thinned right here. So above the neoplasm, it's thinning, almost like a pressure effect, like the neoplasm's pushing up and thinning the epidermis. When we go to higher power, we begin to see what cells we have, and we have spindled, almost I would term them bland cells with somewhat ovoid nuclei, and the cells themselves are in fascicles and whirling, if you can see this. So here's kind of a fascicle right here, see that? And here's kind of a whirling right here. So it's fascicles coming in and out and whirling in different directions that give you this effect. And you look around and you really can't find any mitotic figures. And you know, what's your differential in a case like this? You need to be thinking of, maybe it's a dermatofibroma. So I might want to go to the periphery. And what do I look for in dermatofibromas? I look for thickened, trapped collagen bundles in the periphery, which I just don't see here. Instead of that, I see the fascicles of the tumor cells right here, but I don't see thickened collagen bundles. So I don't think it's a dermatofibroma. And so you're beginning to think, when you see these fusiform nuclei, swirling cells, a leiomyoma. And how would you make sure that you're correct on your diagnosis? You could use immunostains. You could throw on a desmin, which would be strongly positive. A smooth muscle actin would be strongly positive, and caldesmon would be strongly positive. So you probably need to know those 3 for your boards. Caldesmon, smooth muscle actin, and desmin. Those are muscle markers, okay? And since we can't find any mitotic figures and it's desmin positive, this is a leiomyoma. So where do leiomyomas arise in the skin? Where do you find, so every tumor is trying to capitulate its normal histologic counterpart. So where do we find smooth muscle in the skin? We find it in the hair erector muscles, and we find it in the walls of the blood vessels. And this is essentially, these rise from 95% of the time, they're arising from the pilar smooth muscle, the hair erector muscles. Okay, pilar means follicle or hair follicles. So the pilar smooth muscle, the pilar erector muscle turns into a benign neoplasm, which is a leiomyoma. These can also arise off of the walls of the blood vessels, in which case you might have an angioleiomyoma. But anyways, so these arise in the smooth muscle erector muscles. Now, how do you know if it's benign or malignant? Well, in classical Dermpath, you would look for a mitotic figure, and if you found a mitotic figure, you could call it a leiomyosarcoma. Well, we know that if these are confined to the dermis and don't involve the subcutis, even if they have a few mitotic figures, they're really not malignant and they behave very benignly. And you can just conservatively excise them and you're done, okay? But if they have a lot of mitotic figures and they're involving the subcutis and infiltrating the subcutis, then they're termed a leiomyosarcoma, so the malignant version, and they need a slightly wider excision. So those are the issues that you're gonna, and the in-between category, because everyone has realized that even if you have a mitotic figure or 2, they're benign. Some people will call them atypical leiomyomas or atypical smooth muscle neoplasm, just get it out. But really, these behave very benignly, even if you do have a few mitotic figures. But on the board situation, they're going to give you one without a mitotic figure, I promise. So there'll be smooth muscle tumor without mitotic figures, and that's your leiomyoma. All right, case number 6. Let's move on here. Case number 6. Let me turn it around so we can see it right side up. So on low power, we have a thin shave of skin that the epidermis doesn't look to be too involved by anything that I can see at this power, and the dermis doesn't show much going on either. So low power is not going to help us with this. As we begin to zoom in to slightly higher power, we see a few telangiectoses here, a few blood vessels with a few lymphocytes. And as we come up into the epidermis is slightly thickened with slightly enlarged keratinocytes. But what's important here is even though they're slightly enlarged, notice as we come along and we scan along, we see very few, if any, mitotic figures. And the size of the cells is very regular all the way across. So while they might be slightly enlarged and slightly atypical keratinocytes, it's the same throughout the whole, across the whole of the biopsy. It doesn't change cytology. When you have an actinic keratosis or a squamous cell or any cancer, they love to change morphology. They don't follow rules. And when they change morphology, they look one way on one side and another way on the other side, slightly larger over here, smaller over here maybe. But in this case, that's not happening. They're all the same all the way across. So if this came in as a pigmented lesion, maybe rule out a nevus or rule out lentigo. You would basically look at this and say, okay, so I have some enlarged cells. They're the same all the way across. This is what we term a large cell acanthoma. All right. So the name describes it. Large cells and an acanthoma is a benign growth, basically. So a large cell acanthoma. What are some other terms for this? What is a large cell acanthoma? Well, most people think a large cell acanthoma is a baby seborrheic keratosis. So it's the very earliest stage of a macular flat seborrheic keratosis. And as this grows up and gets older, it may stay this way, or it may start to get little buds of keratinocytes coming down all the way across here, in which case we call it a solar lentigo, okay? Which is also a seb that's it's growing up even more. And then pretty soon it turns into huge swirls of cells coming down. Then we call it a seborrheic keratosis. So this is all a spectrum of disease. You've got large cell acanthoma, solar lentigo, and seborrheic keratosis. And this is the very earliest, almost seborrheic keratosis incipiens, if you would. So that's what this is. This is a large cell acanthoma. Now, you might be confused about what's the difference between a solar lentigo and a simple lentigo and a junctional nevus and a macular seborrheic keratosis. Well, I'm going to clear that up for you right now. A lesion is either keratinocytic or melanocytic for this discussion. And if it is keratinocytic, then it is a solar lentigo, a pigmented solar lentigo. If it's melanocytic, it's a simple lentigo. Okay, so a melanocytic simple lentigo would be a few single melanocytes all along the junction, which we don't see here. All right, we do not see that. So this is a keratinocytic lesion. It's a large cell acanthoma. Some would term this also a solar lentigo. If there were a few melanocytes here and it was an early junctional nevus, we'd call it a simple lentigo. All right, so that's the difference between those terms. But the good news is simple and solar lentigo are both benign, right? So some people just sign them out as lentigos to avoid the whole issue, and you'll see that every once in a while. But in the pure classical sense, a simple lentigo is a slight increase in single melanocytes, benign, and a solar lentigo is a solar-induced increase in keratinocytes. Let's move on to case number 7. We're going to turn it up. All right, so we have a punch biopsy that was bisected when it was submitted and immediately at low power, as opposed to all the other cases that we've seen where the epidermis, there didn't seem to be much going on except for the fungal case. We have some serious changes going on either in the epidermis or immediately below it here. And then we have a band of something going on down here that looks like a jumble of inflammatory cells. So we've got a jumble of inflammatory cells here, and we have something going on up here, either within the epidermis or immediately below it. And as we go to higher power, we begin to see that our impression on low power was exactly correct. What we have is a process that is causing fluid to accumulate beneath the epidermis and lift it up from the dermis. And right here, these structures right here are the anchoring fibrils that anchor the epidermis to the dermis, and you can see they're being stretched. They're being stretched by the fluid right there. That's how you know that something is stretching this right here, and it's not a clean split. This is not a subepidermal immunobolus process. It's not really splitting there. It's hanging on for dear life, okay? So you have fluid accumulating right there with the anchoring fibrils just trying to hang on, all right? So we know we have subepidermal edema, okay? And the edema gets so bad that it basically blows out up in the epidermis and vesiculates, all right? And as we come down, we say, well, what's causing all of that subepidermal edema? And we can see that there are all sorts of inflammatory cells here. We have neutrophils that are degenerating and leaving little nuclear debris right here. That's called leukocytoclasis, okay? Leukocytoclasis is simply degenerating neutrophils leaving nuclear debris. Does not necessarily mean vasculitis, but it's a clue to vasculitis. Okay, we also have histiocytes hanging out in here, lymphocytes. There's probably some eosinophils. It's hard to see this preparation. And then there's clusters right here of neutrophils that are degenerating. And let's go see if we can find a vessel, right? Because we're looking for vasculitis now. Here's a vessel running right here. So when you're looking for vessels, look for highways, look for straight lines coming through a mess. So that's a vessel running right down there. And you can see that the endothelium is plump, but I don't see a true vasculitis. And a vasculitis is defined as vessel damage. You can't define a vasculitis as neutrophils because any neutrophilic dermatitis means that neutrophils have to traverse from the center of the vessel into the dermis. So you can't define it by just neutrophils in the wall. You have to see damage to the vessel. And the way you see that histologically is by the presence of fibrin, which I do not see here. So we have a bunch of neutrophils in the walls of vessels, collections of neutrophils, degenerating neutrophils, no true vasculitis that we can find, and massive papillary dermal edema. And that together, my friends, is the clue to the diagnosis, which is Sweet syndrome. Let's go back to low power. So the differential here, when you're on low power and you start to see papillary dermal edema, immediately begin to think of sweets, but there's a few other things. A bug bite can cause this. So go down, look for eosinophils, look for clusters of eosinophils. Bug bites cause neutrophils too, so be careful of that. Polymorphous light eruption can give you massive papillary dermal edema. But there you're not going to have neutrophils, you're just going to have lymphocytes, and you're going to have a conspicuous absence of eosinophils. Leukemia can cause this also. So these could be immature white blood cells, in which case this would be leukemia. Now that begs into the question, what is Sweets? Well, Sweets is more of a pattern histologically than a disease per se. Sweets syndrome is a constellation of signs and symptoms, okay, of which the histologic pattern is one of them, all right? And one major cause of Sweets is in fact leukemia or myelodysplastic syndromes and all those. So you can begin to see that the overlap between leukemia cutis and Sweets, sometimes they can't be separated. Sometimes Sweets is caused by it, other times it has nothing to do with it. But a good 15% of the time, the patient either has it or will develop a myelodysplastic syndrome or frank leukemia. So, you know, it behooves you to go down and look and make sure you don't see blasts or whatnot. But with this many neutrophils, and some of those neutrophils are mature, we're basically at Sweets. And that is Sweets. Let's move on. 8. Case number 8. So here we have a punch biopsy, and what can we glean? Let's get everything we can from low power, okay? Because when you're taking your boards or you're taking a test, just like a multiple choice question, sometimes you go to the answers first. to figure out the question if you don't understand. You can come here and you can see all sorts of stuff before anyone even asks you a question about this. So you can tell where this is from. The clue about where this is from is right here. We have hair ending in the subcutis, okay? Hair ends in the subcutis on the scalp and on the chin in men, and very few other places anatomically. So we know we're on the scalp here, okay? We don't see a neoplasm per se at this power, but you can bet that when you have a huge punch biopsy, the scalp without a neoplasm, 9 times out of 10, they're trying to biopsy either an alopecia or an inflammatory process such as psoriasis or seborrheic dermatitis. So just from this, we haven't even seen the question yet, but we can come a long ways, all right? But what do we see going on here? Well, normally you would see a bunch of hairs ending right down here, but these seem to be involuting a little bit, okay? These hairs are in catagen phase, and it's a little above the scope of this talk, but these hairs are involuting. But what we want to do is we want to figure out immediately if this is an alopecia or not, and I think it probably is. And then we have to, in our mind, determine if it's a scarring alopecia or an inflammatory alopecia, because then your differential gets narrowed down greatly. And immediately what we can see on this one is we see peri-infundibular fibrosis right here. See that fibrosis right there? Normally, these collagen bundles would be looking just like that, coming right up to the hair follicle, but instead we have this fine fibrillar stuff, which is peri-infundibular fibrosis. And then, so now we're going, oh, this is a scarring alopecia. That's basically scar around a follicle. And then we look in the follicle itself and we see very abnormal hair shafts right here. See this? You don't want your hair looking like that. It's all broken up and the pigment of the hair shaft is getting clumped, okay? Just like it looks histology, what would cause this? Mechanical manipulation of the hair, twisting or persistent pulling of the hair causes the hair shafts to break and twist apart into these clumps. This is called trichomalacia. When you see trichomalacia and a peri-infundibular fibrosis, you know that this is mechanical manipulation of the hair, either pulling or trichotillomania and whatnot. So right here, right off the bat, we know that this is trichotillomania or a mechanical alopecia. Some other things that we can glean from here is, like I said, these hair follicles are all beginning to involute. This is catagen. This is early catagen phase, and they're all being thrown into this involution. See how it's coming up right here? It's beginning to migrate upward. This one's actually almost into telogen right here, this small miniaturized follicle. So that's not normal. In a normal scalp biopsy, you should be seeing all anagen hairs. You may see one catagen, but we have 1 or 2 catagens and we have a telogen. That's abnormal. So we have persistent pulling and twisting, and we have involution of hair follicles, and this is trichotillomania. When they persistently twist and pull at their hair, it causes them to involute. So they go into catagen phase, and eventually some of them end up in telogen. If they keep doing this long enough, it scars and is completely gone. But this one at this point is pretty reversible, but after a time, these all scar down and it's no longer reversible. So there you have trichotillomania. Let's move on to case number 9. This is an interesting case. I can't put it right side up because one's to the side and one's up. But what do we have on low power? The epidermis appears relatively spared, okay? And then in the dermis, we have nodules of something going on. I can't tell you what they are at this power, quite frankly. So we're gonna have to go down and investigate. Let's go down and investigate. We want to find out, are these keratinocytes? Are they melanocytes? Are they histiocytes? What are these cells? So let's go down and look. And when we come down, we see that they are kind of round cells with abundant foamy cytoplasm, the larger ones, and then we have smaller ones that look like little lymphocytes. So we've got the larger ones, these are histiocytes. Smaller ones are lymphocytes. And then we've got some histiocytes here that are just huge and swollen with something in them. See, there's some nondescript fluffy stuff in those cells right there. So we've got histiocytes with fluffy stuff in them. And if we keep looking around, So what could that be? That could be anything from organisms. Those could be fungus. That could be histoplasmosis. That could be acid-fast bacilli can do that in an atypical mycobacterial infection, or leprosy could do that. And so what do we want to do? We want to look around before we throw lots of money at this and put special stains on it. Let's see if we can find any clues. And if I remember correctly, and I think I can find it. Yes, it's right down here. Sometimes go to the bottom. Bottom, you find a lot of things. And I'll tell you why, because blood vessels and nerves are running around the bottom down here. I think it's down here, yes. So where these clusters of histiocytes begin to meet blood vessels, there's a blood vessel hiding out down in here. I saw it earlier, but I don't see it now. But right here, and this is really hard to see on this preparation, but see this structure right here? These are histiocytes right here, filled with that foamy stuff, surrounding a round structure right here and invading into it. That's the nerve. So you have a histiocytic process that's surrounding and invading into nerves. And that's almost diagnostic of leprosy, okay? So I would hope on a board situation, they might give you a bigger nerve or something like that. That's a very small one. That's the only one I could find on here. But go down towards the base of the lesion and look for the neurovascular bundles and try to find a vessel. And wherever you find a vessel, sometimes you'll find a nerve right to the side of it because they travel together. And then if you see histiocytes invading a nerve, think leprosy. So what are you going to do next? You're going to throw on your special stains. And you would want to put on a fungal stain like a GMS here to make sure it's not histo or another fungal organism. But if in this case, these were strongly positive for acid-fast bacilli. And most importantly, they were weakly for AFB and strong for phyte stain. And so this is leprosy. Okay, now what's the difference? They love to ask you this on the board. What's the difference between AFB stain and phyte stain? So phyte stain is more sensitive for leprosy, and it's basically an AFB stain with peanut oil added. Okay, and it increases the permeability of the wall and increases the sensitivity of the stain. So that's that. And there's different types of leprosy histologically. You know, there's the histiocyte predominant like this, where you have them, you know, stuffed with the organisms. This is lepromatous leprosy. And you see this in patients that are immunocompromised, all right? In a patient that's not immunocompromised, you have granulomas defined by clusters of histiocytes, often surrounded by lymphocytes, and that's called a tuberculoid granuloma, okay? Anytime you see histiocytes surrounded by lymphocytes, it doesn't mean necessarily tuberculosis, but we call that a tuberculoid granuloma. And in the case of leprosy, it would be tuberculoid leprosy, and that would be in an immunocompetent patient. That's what you would see. And in that case, you would see very few bacilli. Okay, so in the tuberculoid immunocompetent leprosy, you see very few bacilli, and you just see granulomas surrounded by lymphocytes. In an immunocompromised patient, you see lepromatous leprosy, which is oodles of lymphocytes stuffed with the organisms. All right. Let's go on to case number, what is this? 10. 10. Okay, so 10, we have basically, it looks like a incisional biopsy here. So it was quadrisected. They sectioned it into 4 pieces and then submitted it. And when we look at it, I'm sorry. There we go. When we look at it, we can see the epidermis is slightly thickened. All right. We have a slightly thickened epidermis. Then we have an area of sparing in the dermis. Okay. Then we have our pathologic process right here. So we have a cluster of cells with a Gren zone. This is called a Gren zone, just where it spares the papillary dermis and the epidermis. And we have a neoplasm. So let's go down and see what this is composed of. And this neoplasm is composed of histiocytoid type cells, kind of like our Xanthogranuloma. And when we go down, they actually have foamy cells. But if you'll notice, they're not two-toned, are they? Did do you see that there's no center eosinophilic ground glass area here? Instead, we just have these foamy histiocytes. Some of them are multinucleated, and some of them, the nuclei do rim the periphery, but you wouldn't necessarily call this two-tone giant cells or two-tone to remember it. And instead, so we have histiocytes, some are multinucleated. We have this dark pigmented material right here. And when you have dark pigmented material that's very chunky like this and almost yellowish, that's hemosiderin. So that's old blood, okay? And we can see where that's coming from because there's blood back here. The neoplasms, there's little thin vessels that are rupturing and red blood cells are getting extravasated, okay? So that's what we have. What are we thinking? We're thinking of Xanthogranuloma, but we don't have great two-ton giant cells here, do we? And we have all this hemorrhage, which we didn't see last time. So maybe we're not thinking right here. So let's go back to low power. And what I like to do is go to the edge. A lot of times things are at the edge. And when we go to the edge, we begin to see these thickened collagen bundles being entrapped by the process. So immediately you begin to think of a dermatofibroma. And what's interesting about this one is it's more cellular than you're probably used to looking at them. It has more hemorrhage. It has those foamy cells. It has hemosiderin, and it actually has probably a pseudocystic space down here at the bottom. This may have actually been filled with blood in the body prior to the biopsy. So this is a variant of a dermatofibroma called a aneurysmal variant. Okay, so an aneurysmal dermatofibroma, and these often come in as melanoma because they're very dark clinically, but you know, they're completely benign. And how can you you know, you could throw on some stains. Hemosiderin would be iron positive. You can make sure that's hemosiderin instead of melanin. The dermatofibroma should be factor 13A positive. It will be somewhat CD68 positive. But another thing you might be thinking of is a dermatofibrosarcoma protuberans, although they're generally not, ironically, this atypical and this cellular. But if you wanted to throw on a CD34, you could, to make sure it's not a dermatofibrosarcoma protuberans. But you need to be very careful because the periphery of a dermatofibroma, so the very periphery of it around here, is going to be CD34 positive, all right? So don't let that fool you. But the center will be negative. It'll be stone cold negative for CD34, and that's what you want to see, because if this were a dermatofibrosarcoma protuberans, that would be very positive in that area. But that's also a pitfall on a shave biopsy. So if you're just seeing a shave coming across here, right, and you as the pathologist or the dermatopathologist someday, you throw in a CD34, that might be strongly positive right there, and you might call it a DFSP when it's in fact not. And so you need to be thinking of that as a clinician when you're biopsying your patients. Always remember that the periphery of a dermatofibroma can be CD34 positive. So be sure to give your dermatopathologist a deep enough biopsy to make the diagnosis. All right, let's move on to case 11. We have 10 more minutes and 2 more cases, so we're doing good. Here we have a shave biopsy, it looks like, that was bisected, and the epidermis is thickened here. And over here we can see that the epidermis is really thickened with something going on right here in the center. And that looks like it's probably a hair follicle at one time. So let's go down here and see what's going on. As we come down here, we begin to see that we have this, what was probably a hair follicle. In fact, if you don't believe me, there's a hair shaft right there. Here's a hair shaft right there. So you can imagine that this whole area right here is just one of those enlarged with a bunch of cells in the center. So we got to figure out what's going on. So when we go down, we look and we see inside of here, we see degenerating inflammatory cells, and we see these bright eosinophilic fibers. And then as we come to the periphery here, I think it's over here. Yes, there it is. We see these bright eosinophilic cells are getting extruded from the dermis transepidermally into the lumen of the hair follicle, or this dell right here. And we have to determine what those fibers are. If those fibers are elastin, then we have elastosis perforans serpiginosa. If they're collagen, then we have a perforating collagenosis, or a Picker's nodule could even do that. So what do? What stain do we use to figure out if that's collagen or elastin? We can throw on an elastin stain or a Verhoef Van Giesen stain, a VVG stain. And those would be dark brown in an elastin stain. And then we would know that we have elastin fibers being extruded right here. And this is elastosis perforans serpiginosum. What would our differential be here? A perforating folliculitis. But again, in that case, you would have collagen coming through, not elastin fibers. Curley's disease, in patients that are scratching who have renal failure. But again, that would be collagen. You can have perforating pseudoxanthoma elasticum, in which case they would be elastin fibers, but the elastin fibers would be in a different morphology. They would be shorter, and they are oftentimes calcified. Okay, so you need to think of that. I'm just throwing out differentials to stretch everyone's minds and thinking here, but in this case, this is elastosis perforans serpiginosa. All right, let's move on to the final case. Let's see if I can get this. Or what? Let me get. Sorry, I got stuff on my computer here that you all can't see. There we go. All right, this is our final case. We have a punch biopsy of skin where we have clearly thickened epidermis with what looks to be like fluid in between the cells. Okay, fluid in between the cells within the epidermis is spongiosis. If it's fluid in the cells, in the keratinocytes, that's ballooning. Okay, spongiosis is intercellular edema. Ballooning is intracellular edema. In this case, the keratinocytes are not exploding. They're not edematous themselves. This is spongiosis. And we clearly have something going on also in the epidermis right here. And what is this structure right here? This is a hair follicle, okay? And this is the infundibulum of a hair follicle. So we have spongiosis surrounding the infundibulum of a hair follicle. And when we come down onto higher power, we see that we have neutrophils in the epidermis and in the cornified layer, clusters of neutrophils. So we have epidermal hyperplasia, spongiosis, and neutrophils adjacent to a hair follicle. Perifollicular spongiosis, and especially if this is on the face or a typical area of seborrheic dermatitis, this is seborrheic dermatitis. All right, so the take-home point here is spongiosis around the infundibulum of a hair follicle with neutrophils at the lips of the infundibulum, or they sometimes call this the lips. That would be excellent for seborrheic dermatitis. What's your differential here? Your biggest differential would be, well, there's three, I think. You could see this in impetigo, where we have a bacteria here causing this, which I don't see, but we might want to do a gram stain if we really were being careful. You could see this in fungus, okay? And you can also see this in psoriasis. And many of you know that psoriasis and seborrheic dermatitis on the head, and especially the scalp, is very much of a spectrum of disease. So, but in general, for your boards, when it's right around the infundibulum of a hair follicle, go with seborrheic dermatitis, okay? But the differential would be, quote, sebopsoriasis in this case. So there we have it. Well, one other thing you might want to think about, you hear it, spongiosis adjacent to a hair follicle, you hear that in atopic dermatitis. But in general, in atopic, you're not going to get the neutrophils right there. And, you would kind of need a history to make that diagnosis. But take home, spongiosis periinfundibular with neutrophils is seborrheic dermatitis. Okay, so hang on one second. Ida just told me there were 2 questions, but they didn't pop up here. I'll have to answer them later. But anyways, so that's all of our unknowns. We've got 5 minutes, so I'm gonna ask Ida to come back in here real quick and tell me the questions that you all got, because they didn't pop up on mine. They didn't pop up on mine.
In the chat box.
Oh, I can't get to the chat box. Let me see what they are. Okay, so we had 2 questions. Is an aneurysmal dermatofibroma the same as a hemosiderotic DF? Yes, some people would say they're the same. Some people would say they're slightly different, but I consider them the same. And then the other one, are these monster cells of the DF with monster cells or just histiocytes in a DF? Well, the monster cells of a dermatofibroma are histiocytes, so they're the same thing. It's just another term for them. All right. Well, I very much enjoyed this. So if you all have any more questions, feel free to shoot them to me. I know Tom would be happy to answer some also. I think he probably was listening to this. And we hope to see you back. I will be repeating this tomorrow, and I know that it will be up soon after tomorrow, I think, as a recorded session that you all can review again. Again, thank you for participating, and have a great rest of your day.